Hi everyone. We're going to discuss essential diagnosis and management of delirium, and we will be explaining it or testifying your answers to an examiner in this case. Now, um, whenever you're starting a new station, you'll always introduce yourself. So in this case, we are assuming that introduction part has already been done. We have introduced ourselves to the examiner, or examiner knows who we are already. Then we will start with a brief statement or summary of patient's presentation. Here it says 82-year-old male presenting with acute confusion and fluctuating levels of attention based on the rapid onset and fluctuating course. The most likely diagnosis is delirium. Once you give the most likely diagnosis, move on to your differentials. My top differential diagnoses are as follows, or my top differential for the causes of this patient's delirium are as follows. Number one or first, UTI or urinary tract infections, common in elderly patients, supported by presence of fever, elevated WBCs or leukocytosis, and positive urinalysis. My second differential diagnosis is electrolyte imbalance, such as hyponatremia. Sodium was low on lab work. Sodium abnormalities frequently cause confusion in the elderly. My third differential is drug-induced delirium. For example, anticholinergics, opioids, multiple medication polypharmacy. Since patient is on multiple medications and is an elderly, patients in this category are very likely to develop delirium. Hypoxia or silent MI. Elderly patients present atypically. ECG and vitals are essential. We will monitor patient's vitals and get an EKG done to make sure it's not because of a myocardial infarction. My fifth differential is CNS causes such as stroke or chronic subdural hematomas. Um, Elderly patients, especially if they have a history of falls or if there is a focal deficit or taking anticoagulants, we have to rule out chronic hematomas or subdural hematomas and strokes to make sure patient is confusion is not related to a stroke or a bleed. Finally, I'm considering sepsis. Even though patient doesn't have any clear focus, we are ruling out sepsis early to make sure that patient is not septic and they don't go into septic shock, which can be more detrimental. Once you do your differential diagnosis, since the station is also of management, you would start with your management plan. So in this case, since patient is delirious and the likely cause is a UTI, you would present it as my management plan is as follows. I'm going to start with non-pharmacologic, supportive, and then pharmacologic as needed. First, I'm going to identify and treat the underlying cause. In this case, we believe it is due to the UTI. So I'm starting patients on empiric antibiotics for his UTI and sending a culture to determine the causative bacteria and sensitivity profile. I'm also going to correct hyponatremia. We will do it slowly with IV fluids. We are going to discontinue and review and discontinue any medications that could cause delirium. I'm planning on maintaining the following supportive care for this patient. Um, Frequent reorientation, clocks, calendars, familiar objects, familiar music, family members around, making sure patient is well hydrated, has good saturation, good nutrition. Unnecessary lines are to be avoided so that we do not cause iatrogenic harm, since patients with delirium can sometimes pull on their lines and cause unnecessary trauma. We can use one-on-one supervision or sitter if risk of harm to self or others. Usually a nurse or a PSW would be monitoring patient closely. Pharmacologic management, if the patient gets severely agitated or is a safety risk, we will consider low dose antipsychotics such as haloperidol. We are going to avoid benzodiazepine unless the delirium is due to alcohol withdrawal. We will monitor EKG for Q2 prolongations if we are using antipsychotics such as haloperidol. Now, What I'm going to do next is to admit the patient to medical ward, where we would monitor him closely, alert nursing staff about fall risk, initiate confusion assessment method screening daily until patient is out of the delirium. To summarize, in summary, or to summarize, this elderly patient is presenting with acute delirium, most likely secondary to UTI and hyponatremia. My approach focuses on identifying and treating the cause, optimizing environment, monitoring safety, and using pharmacologic agents only when necessary. In this way, you are letting the examiner know that you know what you're talking about. You know delirium, you know the likely causes, and you know how to relate it to your patient who is presenting right now. You're summarizing it for the examiner so that they know that you are not missing anything. Once again, in all cases in which there is confusion or cognitive issues, make sure you are providing supportive care and environmental safety. Patients with confusion or high fall risk, they should be monitored more closely. Their bed alarms turned on, they reoriented frequently to the environment. Family members' presence is great in helping with it if they can be present. If not, you can still manage it with other means like playing their favorite music or turning on their favorite sports, etc. Keeping the environment more comfortable for the patient so that they don't get worse or their delirium does not um, get more severe. All right, so this is how approach to a station with delirium differentials and management should be. The focus should be on um, differentiating the cause or finding the cause of the patient's delirium from history, physical exams, blood tests, urine exams, etc. And then justifying each test that you have done or you're doing for the examiner to let them know that you understand what is causing this patient's delirium.